A 4-year-old child presents with a palpable abdominal mass, fever, and right-sided abdominal pain. I am showing you an axial contrast-enhanced abdominal CT in the portal venous phase. Describe the findings.
Um, let's see. Yes. The axial contrast enhanced CT of the abdomen demonstrates a large, heterogeneous mass arising from the parenchyma of the right kidney. The mass exhibits lower contrast enhancement compared to the normal renal parenchyma. There is significant local mass effect with displacement of the surrounding abdominal organs, but no invasion of the right lobe of the liver. The renal vein and inferior vena cava appear patent. Crucially, a second smaller mass of similar low density is visible within the left kidney, indicating bilateral disease. The diagnosis is bilateral Wilms tumors, and the primary differential diagnosis is neuroblastoma.
I am now showing you a second CT scan. What is the association of bilateral Wilms tumors with nephroblastomatosis, and how does the CT appearance of Wilms tumor compare to neuroblastoma?
Bilateral Wilms tumors occur in approximately 10% of cases and are strongly associated with underlying nephroblastomatosis, which is the persistence of embryonal nephrogenic rests. In terms of CT differentiation, Wilms tumor is an intrarenal mass that grows exophytically and tends to displace surrounding organs and vascular structures without encasing them. Conversely, neuroblastoma is an extrarenal retroperitoneal mass that characteristically calcifies, crosses the midline, and is highly infiltrative. As seen in the second CT scan, the huge neuroblastoma mass displaces the spleen and left kidney and shows typical encasement of vessels, in this case the aorta and coeliac axis.
Detail the clinical presentation of Wilms tumor, its staging, and the significance of vascular invasion.
Clinically, Wilms tumor presents as an asymptomatic, smooth, firm abdominal mass, but can cause pain, hematuria, and hypertension due to increased renin production. Vascular invasion into the renal vein or inferior vena cava occurs in up to 10% of cases and must be carefully evaluated preoperatively, as it affects the surgical approach. Staging is determined surgically after nephrectomy in North America, whereas in Europe, preoperative chemotherapy is routinely administered first to shrink the tumor and reduce the risk of intraoperative rupture.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these CT images with prior renal ultrasounds or chest radiographs to screen for pulmonary metastases, which is the most common site of distant spread. I would suggest performing a detailed chest CT to exclude small pulmonary nodules. I would recommend evaluating the patency of the renal veins and the inferior vena cava using CT venography or Doppler ultrasound. Finally, I would document the findings, assess for signs of nephroblastomatosis, and refer the patient immediately to pediatric oncology and pediatric surgery for multidisciplinary staging and treatment planning.